Welcome to the inaugural episode of Healthcare Rewired, the podcast that explores actionable lessons and insights for improving healthcare from digital health's leading innovators and champions. I'm your host, Mark Noble, and I'm thrilled and honored to be exploring what it takes to create a paradigm shift in healthcare with Dr. Karen Rheuban, pediatric cardiologist, professor of pediatrics, and the co-founder and director of the University of Virginia's Center for Telehealth, which was renamed the Karen S. Rheuban Center for Telehealth in 2016 in recognition of her significant contributions to the field of telemedicine. In addition to all of that, Karen's an amazing human being and somebody I'm proud to call my friend. Welcome to the program, Karen.
Thank you, Mark.
So, Karen, telemedicine was still relatively nascent when you got the program started at UVA back in the 90s. So, what was the problem you were trying to solve when you started to champion telehealth at UVA?
Well, first, Mark, I want to thank you for your thoughtful introduction and invitation to join this very timely podcast. As a practicing pediatric cardiologist, I was one of many of UVA specialty providers who traveled across the state to see patients. In particular, we traveled to Appalachian, Virginia to see children with heart disease every other month for 2 days, many of whom had to travel as long as 7 hours to see us when we were not physically present in our clinic in Bristol. So the challenge we sought to address was limited subspecialty access to care, particularly for rural patients remote from our academic medical center.
That's awesome. So, the approach at the time was radically different from anything else that folks are doing. This whole concept of using technology to bring the expertise to the patient instead of the patient to the expertise is a paradigm shift, if you will, for UVA and many of the constituencies that were involved in this, I'm sure. That kind of change, you and I both know, is not easy to make. So, can you share with us what some of the obstacles were that you had to overcome in order to implement your vision, and how'd you do it?
Well, the first thing I did was I heard Jay Sanders speak when he was director of the telemedicine program at the Medical College of Georgia. But the truth is, when we launched our program, the obstacles seemed insurmountable. This was in the early 1990s. So there was very limited connectivity to rural anchor institutions and clinics. There was a very high cost of equipment to use with codecs and other technologies. There was no reimbursement. There was little proof of concept, and patient and provider really lack of knowledge about telemedicine. There was no electronic medical record and more. I'd
Mm.
heard Jake speak about his Georgia experience and I was motivated. I consider him really my mentor.
Oh, he's a good mentor to have. For those who are unfamiliar with Jay Sanders, he's long considered one of the fathers of telemedicine. Back in his days, early days at MGH, when he and his boss at the time set up video cameras that were, production quality video cameras at the airport in Boston to the hospital, so that they were able to get expertise to where it needed to be without having to fight through traffic. That was the origin of it.
And
But
he was the founding president of the American Telemedicine Association as well, right?
that's exactly right. Yeah, so he's been a stalwart. Um, so uh, so Karen, getting the institution and stakeholders to try out a new model is radically different than getting that to be a permanent practice that's a standard of care, if you will. What were some of your successful, keys to successful transition from pilot to permanency for the program at UVA?
Well, thank you for that question. It was a challenge for sure. But my first step after hearing Jay speak was to meet with our extraordinary dean at the time, to whom I reported, Robert Carey, and our EVP for Health, Don Detmer. Both are great humanitarians. They recognize the need for access. And in
Mm.
particular, Don was a luminary in health IT, and he led the AMIA, American Medical Informatics Association. So they both really understood what we were trying to accomplish. Both gave me their blessing to pursue the model and wished us well. Didn't give us any money, but said, work it out. um, and as you know, the University of Virginia is both a state safety net hospital and an academic medical center, which really meant improving access was aligned with our mission as both, right?
Right.
So at the same time, our neurosurgery department recruited Lieutenant Colonel Eugene Sullivan, a systems engineer affiliated with the Special Forces, to assist with establishing connections across the state for neurosurgery. Gene was a natural technology partner and remains so to this day. We piloted and tested in local community hospitals as a feasibility model because, again, we didn't really have much experience in this space. So our next step then was to reach out to Virginia Medicaid to seek a waiver that would enable coverage because otherwise we would have asked providers to leave their clinics and come down to our telemedicine office and not be reimbursed for services that they were providing. And we do a lot of community outreach, but to make it a regular integrated delivery mechanism, we needed to ensure payment was a possibility. Again, remember, this is before the balanced budget amendment of 1997 that enabled some Medicare coverage of telemedicine. So it was a no-brainer for a pilot for Virginia Medicaid, especially because we knew that Virginia Medicaid paid for transportation. And we had a handle on their taxi cab and ambulance budget every year. So they were very willing to support a pilot. Then next, we had to pick our partners. So we had to identify community partners with whom we could work. And in particular, it was Appalachia for us because we had a longstanding presence of providing on-site services, albeit spread out over every other month or every month, depending on the subspecialty. But I had to have faith in the model and a legislative partner. So I reached out to a powerful member of the Virginia General Assembly, State Senator William Wampler Jr., who introduced us to two federally qualified health centers in his region, as well as to two community hospitals and their CEOs. With their agreement, then we applied for our first federal grant from NTIA Department of Commerce and were successfully funded. And we were off and running in 1996. Again, we didn't have Medicare reimbursement at the time, but we did have a waiver from Medicaid. So that's what got us started.
That's awesome. So, Karen, I am sure in medical school, they did not teach you how to be a lobbyist for government and such. How did you navigate that?
Oh, wow. Well, that's a great story in and of itself. I didn't understand government. I didn't know how bills became law. So I had to rely on our government relations team
Okay.
members to just advise me and also our legislative partners. We worked extensively with U.S. Congressman Rick Boucher and Congressman Tom Bliley, who chair the Energy and Commerce Committee, and their staff members who were incredibly helpful. And in particular, we didn't lobby because we weren't allowed to lobby, but we were allowed to educate. And so we knew about the universal service provision of the Telecommunications Act that had been introduced by Senators Rockefeller and Senator Snow. And we thought that is an ideal mechanism for us to scale telemedicine statewide. When we applied for our first grant from NTIA, the cost of a 1.54 megabit connection to one community hospital in Southwest Virginia. And that was only 1.54 megabits. That's tiny. All of us have more than that in our homes today. It was going to be $6,000 a month. Unaffordable. Who could afford it? And the equipment, $150,000 for a telemedicine system. So the Universal Service Fund was critical to our scaling telemedicine. So again, the link to favorable public policy that can advance telemedicine. And we, of course, were thrilled with the passage of the Telecommunications Act of 1996. And then we've also worked with the FCC in their advocacy for telemedicine all across the years. So in 2003, our governor was Mark Warner, currently Virginia's senior senator. And he, of course, was a technophile himself. And he was able to successfully flip a switch for Virginia Medicaid and enable coverage by Virginia Medicaid, especially when we presented the data of our demonstration of cost of miles of driving avoided for telemedicine services, because it was natural for him to understand what Medicaid was paying for transportation. So that was another public policy transformation that helped us to scale telemedicine. So back with Senator Wampler, with his help, We secured a grant from Blue Cross Blue Shield of Virginia, which enabled us to reimburse our providers at Medicaid rates for participating in telemedicine encounters. Again, trying to make it a sustainable model of care. Ultimately, it was Senator Wampler who introduced legislation to require the commercial payers in Virginia to cover telemedicine. So we had then, with the balanced budget amendment, some Medicare coverage, we had Medicaid coverage, and we had commercial plan coverage. That was that was about in 2010. So you can see it was a work in progress over many, many years.
For sure.
But over the years, we've still been hamstrung by the 1834M restrictions in the Social Security Act that limit eligible originating sites and eligible providers. So we also advocated with ATA and other organizations, including the AMA and the AAMC, since we're an academic medical center, for expanded coverage for Medicare beneficiaries. And you know that we made strides with the FAST Act, enabling telestroke services for urban patients, and the Support Act, expanding Medicare coverage for behavioral health providers. Same is true for remote patient monitoring and coverage for provider-to-provider e-consults in Medicare. I would say the silver lining of all of this, of the COVID-19 public health emergency, was the federal and state waivers that enabled coverage of urban patients, Medicare coverage, and not limiting patients to be seen at facilities and expanding eligible providers. So we and others demonstrated a near thousand-fold increase in utilization, which has really endured post public health emergency sunset. HHS reported that during the public health emergency, more than 28 million Medicare beneficiaries utilized telemedicine. And many states made permanent those waivers, including the Commonwealth of Virginia. I'm very proud of our members of the General Assembly who did that. But for Medicare beneficiaries, we're still hamstrung by the lack of permanent elimination of 1834M. Even though we have the Consolidated Appropriations Act with related extensions of the waivers, that's been a godsend, but not a permanent solution.
Yeah. Yeah, indeed. So it's amazing, Karen, as we talk through this, right? This is a program about health tech innovators and such. And when we talk about what's really been essential to making this paradigm shift, yes, maturation of technology has helped, and we talk about bandwidth and costs and such. That was obviously key, but what I hear as you speak is the importance of engagement with all of your partners internally and externally around the policies that enable that paradigm shift to happen. And I'm sure there's lots of education that takes place for all those folks to understand the why and the how and such that needs to happen in order for those pieces to take place. Really good stuff. As you reflect back, knowing what you know now, Karen, is there anything that you would have done differently in your journey to make this shift?
I think we were hamstrung again by the legislative process. But maybe I'd have shouted a little louder about how important it was. You know, Congressional action requires favorable scoring. And so I think the only thing that perhaps I might have done differently was more data analytics from the outset of our program. Scoring by the CBO and state fiscal analysts are what drives permanency in terms of legislative action.
Yeah,
So I think it is our obligation to demonstrate the value proposition and cost savings of telehealth that enables favorable scoring, including on such bills right now that we have, like the Connect for Health Act, which has bipartisan, bicameral support, but still it sits at the Congressional Budget Office needing a favorable score. So again, it's really that work that has to be done. And if that doesn't happen, we're stuck with long-term uncertainty of payment by the nation's largest payer.
yeah,
So we've made great progress advancing telehealth with support from our clinicians, data analysts, and most importantly, our patients. The patient's voice is really important. And perhaps I might have engaged them even more, although I will say I did bring a patient to testify in Congress in the BIPA 2000 hearings because, we can be saying it, but when you hear the voice of the patient, I think that makes a world of difference.
yeah, for
So I
sure.
think we do have a unique opportunity now to advance telehealth further with the One Big Beautiful Bill's World Transformation Funding. And hopefully we can drive further engagement aligned with the World Transformation Funding too.
Amazing. Karen, one last question for you. So for all of the Karen Rheuban disciples that are out there looking to make their own paradigm shifts, whether it's using AI or some other disruptive technology and such, what advice would you provide them as they begin that journey?
Oh, well, I think uh, realize that work can be done. You can transform healthcare, but you have to have the data, you have to have collaborators and stakeholders, and the patient voice is really important as well. So, I think anybody can do it. I actually have faith in government and the process and be engaged. That's what it takes to make change.
That's awesome. Karen, thank you so much for sharing your incredibly valuable experience and insights with us here today, and for leading the charge in making some significant transformations and changes in the state of Virginia that have others have learned from to benefit healthcare at large across the country. And for those of you tuning in, thank you for joining us. Please continue to join us right here on Healthcare Rewired for more insightful episodes focused on improving healthcare through digital health.
Thank you, Mark.